Good morning, good afternoon to everyone who's joined. We'll get started in just a minute or two. In the meantime, if you'd like to introduce yourself, please do that in the chat box. Good morning, good afternoon, everyone. I think I'm going to go ahead and get started. My name is Grace Chi. I'm really happy to introduce today's webinar, Turning Data and Data Systems into Action, Reaching and Monitoring Zero-Dose Children in Nigeria. I'm the project director for the Momentum Routine Immunization Transformation and Equity Project. We're a USAID-funded project that works toward a world where all people eligible for immunization, but particularly the underserved, marginalized, and vulnerable populations are regularly reached with high-quality vaccination services. We're really happy to have developed this webinar today in partnership with the Zero Dose Learning Hub. The Zero Dose Learning Hub is funded by Gavi and led by JSI Research and Training Institute, and together with 4 country learning hubs in Bangladesh, Mali, Nigeria, and Uganda, the consortium captures and shares evidence about how to reach zero-dose children. Before I start, I wanted to do some quick housekeeping and review the Zoom environment for today's webinar. So we will be offering simultaneous translation in French for this webinar. You can access the French speaking channel by clicking on the interpretation icon at the bottom of your Zoom screen and choosing your language there. You can choose to listen to the webinar in either English or French. Please use the Q&A button that's located at the bottom of your Zoom window to ask any questions during the presentation, or if you need help with the technology. You can use the chat feature to introduce yourself and share any thoughts that you have about share your thoughts during the presentation, but please don't use that to ask questions. When you ask questions in the Q&A button, they're only visible to you, our presenters, and to our technical support team. So if you have any problems, any technical difficulties, our support team will respond to your question privately. We'll also be collecting questions from our speakers and we'll save them for the discussion period following the presentation. This webinar is being recorded, and after today's event, you'll receive an email with a link to the recording. And also, if there are any questions that come up that don't get answered during the Q&A session, we'll forward them to the presenters and share any responses by email to all participants. So we have 2 great speakers today who will be introduced just before their presentations. Right after the presentations, we're lucky to have Rebecca Fields, who will join us to provide her feedback and observations. And then we'll end with about 15 minutes to answer your questions. Our 2 speakers have joined our webinar today, but I wanted to let you know that we recorded their presentations ahead of time in case of technical difficulties. So you'll be hearing pre-recorded presentations, but they will be live during the Q&A session. So please make sure to ask any questions that you might have. So first, I'd like to turn it over to Heidi Reynolds from Gavi, leading the Zero Dose Learning Hub, to introduce the project and our first speaker. Please, Heidi.
Thanks, Grace. Hello, everybody. Thanks a lot for joining us today. I'm really looking forward to this presentation. I just wanted to say a few words before we start about the Zero Dose Learning Hub. Under the Zero Dose Learning Agenda for the Gavi 5.0 strategic period, the Learning Hub is our flagship project, which is taking place in Bangladesh, Mali, Nigeria, and Uganda, with the objective to use evidence to better understand the factors influencing implementation and performance, approaches to identify and reach zero dose and under-immunized children in missed communities. Today, we get to highlight some of the work from the Learning Hub in Nigeria, which is led by the African which is led by AFINET, which is the African Field Epidemiology Network, with their partner AHBN, African Health Budget Network. And today, our speaker Adam is going to be discussing specifically some activities to improve monitoring of reaching zero dose children at the ward level using a lot quality assurance sampling approach, which then provides data on coverage and demand and gender factors, which is used to improve performance. It's my pleasure to present Adam. Adam Atiro, MPH, is a senior monitoring, evaluation, and learning specialist with AFINET, Nigeria, working on the Zero Dose Learning Hub. He brings over 8 years of extensive experience in monitoring and evaluation in public health practice. His expertise includes designing and implementing M&E frameworks, data analysis, and applying evidence-based approaches to improve public health outcomes. And with that, we will turn it over for Adam's presentation. Thank you.
Hi everyone, I am Adam Attahir. I'm presenting on the decentralized immunization monitoring on behalf of the Zero Dose Learning Hub. This is a project that is funded by Gavi and is being implemented in Nigeria by the African Field Epidemiology Network in close collaboration with the National Primary Healthcare Development Agency. As a way of background, the trend of routine immunization in Nigeria remains suboptimal, with Penta-3 coverage estimated at 57% in 2020 as reported by NICS. Recent WUNIC estimate reported Nigeria being home to about 2.1 million zero-dose children. So to improve the coverage of routine immunization, the National Routine Immunization Working Group developed the zero-dose operational plan, and they identify, enumerate, and vaccinate strategies for 100 districts with high number of zero-dose children across 18 states. To effectively monitor and measure the progress in the implementation of these strategies, AFINET, in close collaboration with JSI and the Liverpool School of Tropical Medicine, developed and piloted the decentralized immunization monitoring in Kombozo local government, where it was being piloted. And subsequently, it was implemented in Bauchi, Borno, Sokoto states. The aim of the DIM was to better understand the performance of routine immunization at the LGA while establishing some baseline for key performance indicators in each of these LGAs. The specific objectives include: 1, to estimate antigen-specific coverages, which can be used for monitoring, to understand drivers of low uptake among these districts, and then to use the LQS approach to identify low-performing wards, and lastly, to disseminate these findings at the sub-national level to key decision makers. The DIM adopted approaches relating to the behavioral and social drivers of vaccination framework, which was developed by the World Health Organization and approved by the Strategic and Advisory Group of Experts on Routine Immunization, to understand contextual factors affecting the uptake of vaccination across this. As you can see, these are the 5 key components of the BASD framework, looking at thinking and feeling, social processes, motivation, practical issues, as well as the uptake of recommended vaccines. To achieve the set aim and objective, we adopted a cross-sectional design approach. This study was conducted in 2 districts across each of the 4 states where we have presence, which is Kano, Sokoto, Borno, and in Bauchi. We targeted caregivers and children aged 0 to 23 months of age. We're looking at 2 different cohorts, 0 to 11 and 12 to 23 months. We adopted a classic LQS approach with the LQS at the LGA level. using the LG as the catchment area and the wards as the supervision areas. To select interview locations, we retrieved the master list of settlement from the LGA team. The list was disaggregated by wards and also the estimated number of households in each of those settlements. And using the population proportionate to size, 19 settlements were randomly selected. In each of the 19 settlements selected, we adopted segmentation sampling approach to To achieve this, we worked with the local guide identified by the gatekeepers during the advocacy at the settlement level, and the gatekeepers supported in development of a rough map, which were eventually divided into segments using the number of households in each of those segments. We adopted the use of the table of random number in the selection of the specific settlement where the data collectors worked, and in that selected settlements, households were selected. In each selected household, one caregiver from the target population, that's 0 to 11 months and 12 to 23 months, were sampled, and the next closest door was visited to sample the remaining eligible child. A total of 230 data collectors were identified, recruited, and were trained for a period of 2 days. 2 data collectors were deployed to each of the wards, and they worked for a period of 6 days with an average workload of 3 settlements per day. All data collected were documented using electronic database, that is the open data kits. Findings. The sample size of 4,028 set out was successfully achieved and across the 106 as we initially planned. The average age of this caregiver sample was 28 years with a standard deviation of 6 years. 98% of the caregivers were mothers and were found to be predominantly Muslims and were married. The prevalence of zero dose was found to be about 31% with vaccination variation across different LGAs. This proportion was found to be highest in Sokoto State. It was also found that 84% of caregivers had no formal education and earn about 3 times less than the non-zero dose caregivers. The uptake of prenatal care was also found to be low among zero dose caregivers, with about 71% delivering at home and 45% having no contact for antenatal care at all. These slides highlight the performance of routine immunization across 4 states. Out of the 4,028 caregivers that were sampled, 2,934 had ever received vaccination, leaving about 27% of the children that had never received any form of vaccination. Card retention amongst ever vaccinated was relatively high at 88%, with Kano having the highest number. Penta 1 coverage among both cohorts, 10 weeks to 23 months, stood at 66%, while Penta 3 coverage, that's 18 weeks to 23 months, was found to be 52%. To allow comparison with other surveys, large surveys such as the NICS, the UNIC, we analyzed the same cohort of 12 to 23 months as well. Coverage was, however, found to be less than the national target of 80% across the different antigens. And when compared with UNIC estimates, Penta 1 and Penta 3 was still found to be lower than the reported Penta 1 and Penta 3 coverage at 60% and at 62%. Moving on to the behavioral and social drivers of priority indicators, analysis showed that about 68.5% of zero-dose caregivers are not willing to get their children vaccinated, despite having good knowledge of where to get their children vaccinated. Vaccine confidence and trust in healthcare workers was also found to be high among zero-dose children at 57% and 45% respectively. The ability to pay for vaccination was found to be high across both cohorts, with some exception in Sokoto and Bauchi. Looking at the proximity of the zero-dose caregivers to a functioning health facility, it was found that about 57% of the zero-dose caregiver actually live within a short or trackable distance to the health facility, as shown in the next slide. This slide shows the geospatial analysis of Kumboso local government as a case study. On this map, we have three distinctive features. The first feature is the ward boundaries, the 11 wards in Kumboso local government, the geo coordinates of caregivers in red and in green, the green depicting non-zero dose caregivers, while the red depicting zero dose. And lastly, the geo coordinate of health facilities with 5-kilometer radius as a buffer. It can be seen that almost all the zero dose live within 5-kilometer radius of a functioning health facility, signifying that access in Kumboso local government might not be an issue. For the last objective of this assessment, that is to identify low-performing wards, we adopted the standardized LQS table. This table shows the decision value for specific sample size and target coverage. As you can see, for the study, we have adopted a sample size of 19 and a target or the national coverage target of 80% across all the antigen. Therefore, if you triangulate these together, we realize that the decision rule for our comparison at the ward level will be 13, as we have compared in the actual data in the next slide. To identify accepted and rejected lots, we aggregated the number of children who have received specific antigens and compared this number with the decision rule of 13. Lots or antigens that performed greater than the decision rule of 13 were therefore colored in green as accepted, while those that were less than 13, the decision rule were colored as red, that is a rejected lot. Cells shaded in green are accepted, while the red are rejected, and the number of children counted for each of those antigens. As we can see, there is an increase in the number of rejected lots as the vaccination progresses. This shows that some of the children were dropping off as the vaccination progresses. And it can also be seen that 2 wards, Kurege and Sani and Kumboso wards, had the least performance in Kumboso local government, while Naibawa, Panshekara, Guringawa, and Chalawa at least had some good number of accepted lots. This information is therefore used at both the LGA level and at the state level to identify and prioritize the type of interventions that will be implemented at a different level. So therefore, interventions that will be applied to Ngwanrimi and Kumboso will be quite different from the interventions that will be implemented in Naibawa, Guringawa, and other wards. However, it can be seen as well that for Mrs. 2, all the wards failed the lot. So a uniform or a uniform approach would therefore be applied to all the wards with these regards. Using this approach, we prioritize 72 out of the 106 wards with different intervention and target population for different interventions. So we believe that this will allow this will allow healthcare workers, allow LGA and decision makers to focus more on the areas where we have more issues. We had some challenges implementing this activity. All the zero dose and partially immunized children that were identified were referred to a health facility and their line lists were shared with the LGA team. However, the team was unable to track uptake of this vaccine. It would have been very nice to have a mobile team accompanying the survey team so that those children can be immediately vaccinated. Other challenges encountered include issues with the master lists of settlement that were provided, that as well as the fact that the survey was implemented predominantly in the northern part of the country, leaving us with opinions of Muslim-dominated results, and were unable to explore other opinions of other religions. As a way of recommendation, we feel there is a need to scale up this intervention, especially in zero dose implementing states, for proper monitoring and tracking the reduction in the number of zero dose. We also feel that there should be targeted outreaches while improving on the dialogue and the sensitization, especially to the heads of households for permission seeking at the household level. So this is the conclusion of my presentation. Here are some pictorials of the activity during implementation. Thank you very much for having me. Over.
Thank you, Adam, very much for that excellent presentation. It was very interesting to see how you use the data from the LQAS sampling methods to prioritize the wards that needed more assistance. And also, it would be great to hear more about how you differentiate
Hi, everyone.
to improve performance in those wards. So just a reminder to everyone on the webinar, please type any questions that you have in the Q&A box. So next, I'd like to introduce our next speaker, Dr. Saadatu Ibrahim Ringam. She's the Jigawa State Immunization Advisor for the Momentum Routine Immunization Transformation and Equity Project. She has over 2 decades of extensive experience working in immunization, malaria, disease surveillance and notification, and nutrition and breastfeeding programs. She's worked on projects with USAID, UNICEF, and WHO in the areas of integrated primary healthcare services, immunization, child health, and polio. So Dr. Saadatu will present on how data from the Digital Routine Immunization Supportive Supervision Checklist, DHIS2, and immunization registers are used together to monitor and reach zero-dose and under-immunized children in Jigawa. So let's pass it over to Dr. Saadatu.
Good morning and good afternoon. I'm Dr. Saadatu Ibrahim Ringim from Nigeria. I work for JSI on the Momentum Routine Immunization Transformation and Equity Project. I'm based in Jigawa State of Nigeria. This is the outline of the presentation, and I'm sharing our work on triangulating data to monitor and reach zero-dose and under-immunized children in Jigawa. The project in Nigeria, the project works towards the overall goal of improving routine immunization outcomes and zero-dose reduction through these objectives of strengthening leadership and coordination, improving service delivery, strengthening community engagement and linkage to primary health center, and improving data quality. We are in 5 of the 36 states of Nigeria, and Jigawa is one of them. This is just to share a little on the profile of Jigawa State relating to routine immunization indicators. Jigawa has a population of under 1, slightly below 300,000, and its indicators of Penta 1, Penta 3, and PCB from the National Indicator Cluster Survey are all below 80%. More than 60% of the settlements in the state are more than 2 kilometers from their health facilities, and there are about 776 health facilities, PHCs. Now, to discuss on the use of routine immunization supportive supervision to expand data on zero-dose and under-immunized children. The routine immunization supportive supervision is a statutory responsibility of government staff that work under routine immunization program. It has an open data kit-based tool which is used for supervision. The tool has prompts that guide the supervisor to check different aspects of vaccination session. It is a critical approach to building the capacity of the health worker, that is the supervisee, and those that conduct the supervision are the state team and local government area team of that working under routine immunization program. And they conduct it every month, and they have a plan of the number of facilities to visit for the month based on guidance by data. Responses of all the health facilities are collated, and the feedback is directly given to the health worker on site for the particular facility that benefits from routine immunization supportive supervision checklist. Analysis of the submission is done on monthly basis and feedback is provided during the review meeting. The routine immunization supportive supervision checklist has two components: the health facility component, which is the operational component, and the community survey component. The health facility component examines identifying information on the health facility, the findings, observation during session, data management, how it is done, and then has a little section on exit interviews with patients and caregivers, while the community survey component has a simple tool for sampling eligible children within the catchment community of the health facility, just to assess the reach of children by the health facility. The analysis of submissions for Q1 and 2 of 2024 of routine immunization supportive supervisions conducted. About 3,821 of them identified 1,744 children not immunized and 3,721 children partially immunized, which were also all reached with vaccines. A major limitation of the community survey component is that resources are only adequate to reach settlements that are close to the facility because of the far and difficult terrains for the supervisors and the resources available. The project customized the community survey tool to enhance the reach of additional settlements and children using the RISS visit or integrated with other immunization activities such as National Immunization Plus Days and outbreak response vaccination. This ODK is also on, this checklist is also on ODK, and the expanded community survey component samples additional 2 settlements, so as a total of 30 children are checked from 3 settlements within the facility catchment communities on their immunization status. Identified 0 dose and under-immunized children are reached with vaccines and followed up through the health ambassadors and records on the tickler box for subsequent doses in the facility. These are some of the results of the expanded community survey, leveraging on diphtheria outbreak response that held in the state and National Immunization Plus Days, and also looking at non-zero dose LGS supported health facilities. And these are some of the 0 dose children identified and reached, as well as partially immunized children from the total number of sampled children. Now, looking at triangulating across data source, the use of data from DHIS, RI settlement register, and the RIODK checklist actually provide ways of projecting from the DHIS2 coverage based on targets to identify where the missed children are based on the analysis, and then further into the register at the facility level to identify which settlements are contributing for the number of 0 dose children identified from the DHIS2 analysis. And then the RISS ODK checklist now reaches out to those settlements to really identify and ensure reach of those children that are missed as well as partially immunized. The integrated disease surveillance and response data is an additional data source to further guide reach for 0 dose and under-immunized children. These are steps to identifying and reaching 0 dose and under-immunized children. Once the 0 dose and under-immunized child is identified, if he is located in a fixed post settlement, he is referred to the fixed post if the session is ongoing as the community survey is happening, and immunized. However, if it's identified in an outreach settlement, which is supposed to be further away from the facility, and caregivers may not be able to reach the facility, the list of the identified children are compiled, submitted to health worker, and outreach sessions are planned, and children are reached. In all these two cases, either children identified as missed or under-immunized from outreach or fixed settlement, they are linked to community health ambassadors and documented in their registers for support also to follow up. This dashboard is showing the number of penta-1 immunized, unimmunized, in the 27 local government areas of Jigawa State, looking at January to June data, and LGAs having under-immunized children further supported. For example, in this second dashboard, Jahun LGA has its analysis of DHIS2 data flagging health facilities with higher number of the number of zero-dose children identified, and they are further supported to do the settlement analysis. Now, having identified the zero-dose children, top of outreach are supported by the project. And from June to August, 801 outreaches are supported, and almost 8,000 children were reached with various antigens across the state. Talking about improving data reviews at the health facility and LGA level, the RISS checklist section on data allows supervisors to conduct data quality checks for the previous month. The monthly health facility data quality spot checks with support of the project in selected health facilities also helps in reviewing and triangulating different data tools to ensure quality and correction on the DHIS2. The revised National Data Quality Assessment Tool application was with support to Jigawa as one of the states for the pilot, was also another area that was used to support the state in improving data quality. Then the monthly data validation and RI program review meetings held also provide an opportunity, and feedback from supervisions are provided, and health facilities helped to review their performance. The performance projected at RI review meetings and RI from RISS finding inform decisions on which health facility to be targeted for following month RISS and community survey engagement. Just to share lessons learned so far from the support to the state by the project, actions are taken on-site to close both operational gaps and reach identified zero-dose and under-immunized children with vaccines. Importance of triangulating data and using the data that is even good, reliable data is not helpful if it is not used. Supporting data use at lower level allows more tailored and timely response, that is at the facility level. Data and data analysis are only as good as the follow-up. In the end, results come from improving service, more engagement with communities, and more outreach services. Institutionalizing accountability for routine immunization supportive supervision is a good strategy to addressing zero-dose and under-immunized children using the community survey component. Approaches to identify and reach underserved settlements will vary across states, LGAs, and the context. It will require flexibility, innovation, and the expertise of organizations to work in a range of fields to improve RI program. And lastly, it requires LGA leadership, civil society organizations, and other relevant stakeholders to address under-immunized communities. Thank you.
Thank you, Dr. Saadatu, for that excellent presentation and sharing those lessons. It was very interesting.
Good morning.
To hear about, it was very interesting to hear about how Nigeria is using multiple data sources to locate reach and monitor zero-dose and under-immunized children, and also about how data from the monthly review meetings are used to inform which health facilities to target for future supportive supervision. So before we move to our Q&A, I wanted to invite Rebecca Fields, who is the technical director for the Momentum Routine Immunization Transformation and Equity Project, to provide her observations and takeaways from our two presentations. So
thank
please,
you very
Rebecca.
much. Thanks, Grace. And a big thank you to both Adama Atahiru and Saadatu Ibrahim Ringam for really excellent presentations that put such an emphasis on how data are not just collected and analyzed, but also used. And we, heard about very different ways, different methods for the data collection, analysis, and use, and how they focused on identifying and reaching zero-dose and under-immunized children. From Adam, we heard about the technique of lot quality assurance sampling and using it in sort of novel ways, both to estimate coverage, but also applying the method to understand the behavioral and social determinants of immunization in line with the BEST model. And in doing so, they were able to identify not just the low-performing wards in terms of zero-dose and under-immunized children, but really gain an in-depth understanding of community perceptions of vaccines and vaccination and reasons why vaccination services would or would not be used. And particularly interesting was the way that they used lot quality assurance sampling to examine and then contrast and compare the perceptions of vaccination among all respondents in the survey versus just those caregivers of zero-dose children. And there was one particular slide that he showed that gave these comparisons and really well worth another look because it showed that there were some distinctions between zero-dose families, zero-dose respondents, and the full range of respondents. Some responses were very similar and others were very different. So for example, among the families of zero-dose children, respondents from zero-dose children, there were lower levels of trust, higher challenges in terms of affordability, a lower perceived value overall of vaccination. On the other hand, the knowledge among zero-dose families of where immunization services can be obtained was relatively high. So that kind of information really helps to focus and sharpen vaccination strategies to really reach those zero-dose and under-immunized children and families. And then from Dr. Ringam, we learned about the use of routine immunization supportive supervision in Jigawa State, and how it includes not just a facility-based review of performance, but also that community survey element that she noted. And she also pointed out that there's both a limited community survey and an expanded version. And she also did a great job in highlighting how different types of data, different sources of data relevant to immunization have been triangulated and brought together to help identify the local government areas and wards that are most in need of targeted planning and delivery of vaccination services for the zero-dose children. Now, one complication that she noted was that sometimes the different sources of data don't agree with each other. They don't always depict the same situation. So that requires the types of processes she described, further analysis and some real judgment calls on the parts of health officials to use those data to target services. One thing that struck me in hearing the presentations was that it does require resources to carry out data collection and data analysis and use exercises. And one point that struck me that Dr. Ringam brought out was that the routine immunization supportive supervision, it's a government responsibility. It does include that community survey and the expanded survey, but she also mentioned that those community surveys are not always carried out due to lack of resources, lack of transportation, relatively lower priority and motivation placed on them. It does require the transport. It does require high motivation and time and effort on the part of health workers, health personnel, to go out to settlements that are at some distance from facilities. But if you only go to the nearby health facilities and don't go to those ones that are at a greater distance, then there's a risk of overlooking those settlements that are at a further distance and where access is likely to be a bigger issue. And also, if those children are not captured in that community survey, if they're not identified, then there's the risk as well that they won't be reached. And if they're not identified in the first place and their numbers are underestimated, that risks giving rise to a more optimistic picture of coverage and performance across the LGA or ward than might actually be the case. One last point that I just want to bring up is that it's interesting to compare the methods used by both speakers in terms of their objectives. What were they trying to achieve? And this in turn has some implications for the frequency with which they may be used. So Dr. Ringham, for example, described methods to use data that are generated on an ongoing basis, coming from supportive supervision, the RISS, coming from IDSR, coming from settlement registers and so forth. So these are data that are generated on an ongoing basis and therefore can be used to inform continuous monitoring, continuous planning, continuous updating of plans. The use of lot quality assurance sampling that Adam described, especially examining the perceptions of zero-dose families, is particularly useful in a formative research sense of informing and refining strategies, including those for social and behavior change. Again, that contrast in data, in findings between the full set of respondents and those who were zero dose is of particular interest and provides very, very useful information for sharpening strategies. So those were a few of my takeaways from the sessions, from the presentations, those excellent presentations. Now, Grace, I'm going to give it back to you for the Q&A part of the session. Over to you, Grace.
Thank you, Rebecca, for those insightful remarks. I'm going to pick up on one of those and also tie it together with one of the questions that's in our Q&A box. And I want to encourage others to also continue to put your questions in the Q&A box. And that's about, the question comes from Carol Hooks. And it's about whether it would be possible if supervisors made it to the hard-to-reach areas and did the community survey there in those very far away, hard-to-reach areas, which Rebecca, you and Dr. Saadatu pointed out is difficult even for the supervisors to get to. It might help the people recognize the importance of immunization more, that someone made an effort to move to those areas. So maybe I'll first ask Dr. Saadatu to answer that, and then also Adam, whether he would like to come in as well.
Thank you very much. Good morning, good afternoon once again. Indeed, supervisors find it difficult to reach. So one innovation that is done in Jigawa, for example, is supervisors from the LGA are usually domiciled in different communities in the LGAs, different wards, and the ward focal persons also and the in charges of the facilities. So they are made responsible to reach out to any settlement that is identified in the registers of the facility as likely having chronic missed children to conduct community surveys there. And these are some of the ways that those distant and far-to-reach settlements are actually reached using the limited resources. And with the existing community structures, especially the innovation that Jigawa has of Jakadun Lafiya, which is a Hausa term meaning health ambassadors for each settlement. They work, the supervisors work hand in hand with those Jakadun Lafiya who have registers that they track children and the status of immunization. As soon as a child is born, he is registered in the Health Ambassadors Register. And so they work with them to create awareness, to enlighten them so that they can track their communities, use other existing structures like the traditional birth attendants and women mobilizers to create awareness, move house to house, and so be able to reach caregivers and their children. These are some of the ways that actually, one, we're able to use the limited resources, using health workers close to their communities to conduct surveys, as well as engaging with the community structures in those settlements to mobilize their wards to access service and inform them of the importance of immunization.
Thank you for that answer. Adam, did you want to add anything here?
Yes, thank you, Grace. Can you hear me?
Yes.
Yeah. So for the implementation of the LQS, I think one innovative strategy we adopted was the inclusion of the LGA team into the supervisory team. So most of the settlements that were visited were actually visited by the LGA and the state team. I feel that's really improved, or it really strengthened the capacity of the LGA team, because they were able to identify real time what the problems were on the field, and immediately most of them were swinging into action. I remember this particular community that was visited, and there was a block rejection. The whole community do not actually believe in vaccination, and they don't allow any sort of vaccination to happen there. Fortunately for us, we were together with the incidents manager of the Emergency Coordination Center, EOC, and immediately swept into action and was able to resolve that issue. We also encountered some measles cases during the LQS approach in the field, and the LGA team used this opportunity to actually, sensitized and ensure that those children that were identified that were actually zero dose got vaccination within the shortest possible time. So as Dr. Sadatu said, there may be some logistical challenges, but the LGA team, once they have the opportunity, are really ready and willing to go overboard to ensure that these children actually get immunization at the end of the day. Thank you, and over.
Thank you, Adam, for providing that additional information. I'm going to move on to our next question, which I will paraphrase a lot. It comes from Alan John, and he's asking about the role of gender in immunization. So he's wanting to see whether there are additional indicators to gather around gender barriers to immunization. Any suggestions beyond gender disaggregated vaccination data and maternal education levels? I wonder if each of you could speak to that, and also maybe talk a bit more about other gender-related barriers and other interventions that are being used to address these barriers. Maybe first I'll let Dr. Sadatu speak.
Thank you, Grace, and thank you for the question. Just to highlight the issues in Jigawa, it's a state in the northwestern part of the Nigeria, predominantly Hausa communities, as well as Fulanis and Muslims. So one key gender issue is about the consent that has to be sought by the mothers from their household heads, that is the heads of households, the fathers. And there's a lot of activity towards awareness creation to men in the state, and through the religious bodies, through in the mosques and worship places, other gatherings, to create awareness, to have men have open invitation passes for women to access immunization for their children, having been informed of the importance of vaccination. Cases of non-compliances do exist, and quite a number of them are related to lack of access to other health-related services. And once identified, they are addressed. And quite a number of them also are related to other beliefs, traditional beliefs, and they are usually addressed. The state has been able to map up across all the 27 LGAs some non-compliant settlements and also sporadic households within settlements that are non-compliant, and they are providing a lot of community engagement activities, education, information on importance of immunization to be able to get caregivers to access service for their children. So it is really on the decline, issues of non-compliance, but they do exist, but they are becoming a few, and issues of outbreaks are used to provide information on need for getting children to be vaccinated, and caregivers having live examples that if the child is not vaccinated, this is likely to happen, the disease outbreak and the rest of them. So we are getting more compliant households and caregivers by the day.
Thank you for that. Adam, do you want to come in here to speak about gender-related issues and gender indicators?
Yes, Grace. Thank you for that question. I think that was a very excellent question, and this we have seen firsthand on the field. During the field data collection, we have a question asking the caregivers of what are some of the key gender issues that they encounter that prevent them from accessing care, both for themselves as well as for the children. And one key issue that came up repeatedly was the fact that a lot of them, being predominantly in the north, that they need to seek permission from their husbands, which is a cultural norm, and also from the religious perspective, that wife takes permission before going out, and for them to get the children vaccinated, they have to seek for the permission of the husband. And this was a finding that we found to be very significant, and we are working with the team to ensure that we incorporate this into the demand generation activities towards targeting the health of households who give this permission for the children to actually get vaccination. We've been targeting caregivers with these key messages on RI, but I think it's time we make a shift from these caregivers directly to the head of households who actually give the permission. Another key issue around gender is the power for them to make also decision based on the income they earn and also their level of education. I think this is also, even though it's not something that can be addressed immediately, but probably for upcoming projects to also look into how to improve the socioeconomic status of zero-dose caregivers, and also how to improve on the educational status. We believe that through sensitization and building these two key indices, probably health uptake, both the antenatal, it will reduce home delivery as well as reduce zero dose across the different states. Thank you.
Thank you for both those great answers. I want to ask another question. I think this is more directly to Adam, which is, how frequently do you implement the LQAS, and is it a cost-effective way to use it to continue to monitor changes? And then a follow-up to that is, how are the findings of the LQAS's use? How do you translate this into changes in coverage? That question comes from Abdul Gayor. Adam, can you go ahead and respond to those?
Sorry, can you repeat that?
There were two questions from Abdul Gayor. One was about how frequently you would implement the LQAS, and whether this is a cost-effective way to monitor changes in immunization. And then secondly is how do you translate those findings of the LQAS into results?
Yes, let me start with the second. I think the implementation or course correction of the findings actually began from the field when the LGA team and the state team actually saw the key findings from the field and were able to actually address some of them. So immediately the IM gives some instructions to be implemented at the LGA based on what he saw on the field by himself, and that's actually informed some changes in how they conduct their supervision and how they also address some of the non-compliance cases. With regards to the formal dissemination, this data was completed. Data collection was actually completed earlier this month, which I think on the 4th. So the plan is for us to disseminate across three levels. We will intend to disseminate at the community level where we will have all the religious leaders because there are cultural issues that needs to be addressed. We are going to be inviting the facility in charges for us to sit and think together how to address some of these issues. We'll also be disseminating at the LGA level where where we feel there are decision makers and the program managers. So we are going to develop a plan to complement the Z-drop plan that they're already implementing. We believe that together, this will make the implementation stronger, and it will also be target-oriented using the evidence that's been generated. At the state level, we are going to have a statewide dissemination where other LGs can also learn from what we have implemented and the strategies that they need to adopt to cross-correct what they are currently implementing. With regards to costs, I want to assure you that this implementation was cost far less than what we usually think the cost of implementing LQA is, because we actually adopted the use of local state team to collect the data, and this was really found to be very cost effective. The main cost drivers were the payment of the data collectors as well as the cost of supervision, transportation, going to very far to reach areas to ensure that the team actually comply with the protocol as well as the guideline that was laid down for implementation. So far, I think it's data that we can use to inform course correction and also to take decision at the different levels that there are. Thank you. And over.
Thank you, Adam. We only have about 1 minute left, but I thought that there was an interesting question that just came in. I wanted to ask both you and Saadatu, maybe Saadatu first to respond. The question is about, Adam had mentioned that we might shift the focus from the caregiver mainly to the decision maker. How would we do that? Saadatu, do you want to speak to that and how that has been done in Jigawa?
Thank you very much. In terms of shifting the focus to the decision maker, it is about the accountability issues and the focus in terms of technical capacity of doing the analysis, for example, in terms of data and providing some guidance on how to inform the program implementation. So for me, that will be the focus for the decision maker in terms of ensuring accountability that every program officer at different level implement what is in their role and responsibility, and also in terms of having the capacity at the state level to provide guidance, mostly state level and then LGA level, to provide guidance in terms of how to better inform the program based on lessons learned and data that has been analyzed to be used for action to close gaps. Thank you.
Thank you. Adam, do you want to very quickly address that? before we close?
Yes, I think I completely concur with Dr. Saadatu. I think to change behavior is not easy. It takes a while. It's a gradual process. However, setting the tone for behavior change is very important, and we can actually start gradually and with repeated implementation, we believe that the behavior of the people, caregivers, will actually change. With regards to under-immunized children, I sincerely feel that there are contextual factors preventing them, and that this we have noted, and we're working with the LGA team to see how we can mitigate those challenges, and that's the whole essence of implementing this survey, so that we can identify, prioritize, or potential barriers, and see how we can work to mitigate them at the end of the day, and provide the opportunity for continuous uptake. Thank you very much.
Great, thank you very much. So I just wanted to take an extra minute to thank all of our speakers, Adam, Saadatu, Rebecca, for sharing their time and expertise with us today. We will follow up, as I had said, with any questions that couldn't be answered. You'll see there's a link in the chat to an evaluation, and we really appreciate if you could take 2 minutes to provide feedback on this webinar. It's very valuable to us, and we will be sure to use it to improve future webinars. So thank you all for joining. We will follow up with an email to today's recording. Have a great day.
Thank you, Grace.
Thank you, Grace, and bye-bye, everyone.
Thank you all. Bye.